Okay, how about now? Great. I love that for us. Hello, everyone. Welcome. Thanks for joining us. We'll go ahead and get started. I wanted to say that we are in a meeting format, so feel free to engage with each other in the chat as well. I think everyone is set to mute as they come in, so hopefully we won't have any background noise with that. But thank you all so much. So we're here in a three-part workshop series called STI Service Integration into Incarceration Facilities. And this first part focuses on planning for partnerships. Just a couple of housekeeping items. We're aiming for the recording and slides. Let me go ahead and press record, make sure I'm recording. Let's double check. Yes, we're recording. We're good on the recording. Recording and slides will become available within a week on the workshop event page, which is on our NCSD site. If you click to events, you'll see the incarceration facilities event page. Again, we are in a meeting format, so please feel free to engage with each other in the chat. We also have, if someone can double check, let's see. Oh, yes, our chat is working. Cool, chat is working. And then I believe we also have Q&A ability within, if I toggled it correctly. So feel free to add your questions in there as well. If you have any accessibility needs, please feel free to direct message Leo Parker, or if you feel better, more comfortable, you can email him. His email is listed here, lparker@ncsdc.org. And in the future webinar, we actually listed that as a registration question. So hopefully we'll be able to accommodate anything ahead of time for the next upcoming webinar. And at the end of our series, we will have a survey that'll pop up. If you all wouldn't mind filling that out, that helps us make sure we're getting you the information that you all need. If anyone needs closed captioning, there is a button here on the bottom that allows you to enable closed captioning. And then if you have any questions, feel free to press the raise hand button, and we will be able to know that you have a question. So just a quick overview, we're going to go over goals. We'll go over a little background. We'll discuss briefly considerations for partnerships with incarceration facilities. And then we're going to hear from Public Health Seattle and King County, and we'll follow up with a discussion with them. And then we'll see about what we can expect next. So overall, we have a couple goals for this workshop series. Again, this is a three-part series. So firstly, we wanted to allow folks to have the space to identify the needed partnerships, staff, and resources to integrate a set of STI services into incarceration facilities. We also want to allow everyone to identify the logistics needed to effectively implement those services. And then we don't want to forget about assessing ways to measure the impact of service and how we can improve our services and make them sustainable. For this specific one, for this first part, we're going to focus on assessing our programmatic need for STI services in incarceration facilities, which I will now abbreviate as IF, since that is a mouthful, and also identifying partners and key individuals needed to successfully establish those services within IFs. So going a little bit into some of the background of how we got here, how did we get to this conversation? So part of our role as the National Coalition of STD Directors is to facilitate a peer exchange and support our STI field in emerging challenges with translatable technical assistance. So we have a platform. If you're not familiar with it, it's called MyNCSD. If you go to our website, you can sign up to become a member within MyNCSD, the online community, and you can engage in a lot of these conversations. I'm seeing a lot of really familiar names, and so I'm glad that you all are able to make it here today and join us. And really, this is a community space for us to have some of these more informal conversations. So some of the questions that our colleagues posed there were, how are other areas establishing relationships within IFs? What are some best practices that folks are using that they found success with? Is there an MOU of sorts involved? What does that look like? What kind of work is currently being done, and how are DIS involved? One question that has come up in many different threads within the community was, How are testing and treatment facilitated? Is it free? Who pays for it? Who treats the patient? And is it the responsibility of jail health services or the local health department to follow up with that treatment? And then also, what role do DIS play and how are partner services conducted? How do we prioritize what needs to happen, what doesn't need to happen? And knowing that some folks may be released before they receive treatment, just some things to think about as folks were having these conversations. We followed up then with a chai chat, which, if you know me, you know that I enjoy an afternoon chai. Here's, okay, it's coffee, not chai, but my chai is here. So we wanted to facilitate a space to continue that conversation in a peer exchange format. So we held an informal chai chat. And we had some really great conversation and questions that were posed from folks that were able to join that. So who is covering the cost of testing? How are we funding this treatment? Who is administering the treatment? How is that happening? Are we delivering by fill-in? What does that look like? And what does the overall process of testing in the IFs look like? So that's kind of where we got the meat of it. And then around the same time, several of us at NCSD received individual requests from some programs seeking support on implementation of testing. So here we are today. Hopefully, you all can benefit from from this larger conversation, and we want to continue this conversation and encourage exchange amongst everyone. So please, again, engage in the chat. Feel free to connect with us outside as well. One thing that, oh, sorry, Leo, you can go to the next slide. Leo has my slides. So one thing that, a couple things to think about as we're thinking about considerations for planning for partnerships. So what sort of information is needed to garner buy-in from leadership and possibly senior leadership to support testing initiatives? What resources will we need? Who are the individuals or parties that we need to build strong relationships with to be successful within these facilities? What services will be prioritized? Are we only going to focus on syphilis? Are we only going to focus on HIV testing? Will interviews be conducted by DIS, or are we just going to focus on supporting treatment, making sure that that happens? And what resources will be required? Do we need to acquire rapid testing? How will we pay for those? How much testing is going to happen? Is it going to be maybe once a week, or is it going to be X number of tests per month, for example? And also, how do we prepare to implement this partnership? So do we need additional staffing? Does that staff need additional training? And are there security clearance necessary for those staff? So while I'm sure it's no secret to anyone that's here in this conversation that working within our resources and in incarceration facilities, there are very unique challenges. And one thing that someone said in the chai chat was, instead of us focusing on limitations, we should focus on how can we make this happen. And I'd really like for us to lead with that in mind as we hear from our guests. I'd like to introduce from Public Health Seattle and King County, Dr. Julie Dombrowski and Luis Enrique Herrera Perales, who is a DIS there.
Wonderful.
Thank you. Julie, I think, let me know if you have any issues switching over to screen share.
Yeah, it's telling me I can't do that while you're screen sharing. So I think you need to stop. You got it. Got it. Okay, and Sonia, can you confirm that you see the right screen now for the presentation? Okay, wonderful. Thank you so much. It is really exciting for Luis Enrique and I to be here with you today. I really appreciate the opportunity to talk in this kickoff meeting and look forward to the discussion, which we want to make sure to leave plenty of time for. So I'm going to begin by discussing briefly the background and rationale for our testing program in one jail in King County. Luis Enrique, who does the testing, is going to talk to you more about the operational details and implementation of the program and show results of our testing to date. And then we'll both finish up at the end with some lessons learned so far. So a big part of what drove our testing program was the need to find new approaches to syphilis in King County. We really have a completely uncontrolled syphilis epidemic in cisgender women. You can see on the right there a slide that shows the massive increase over the last few years in red among cisgender women of primary syphilis, but also all stages of syphilis. And we have a persistently high level of syphilis among MSM that has been more stable. Most of our programs were really designed to test MSM and depended on specialty clinics or outreach events. And really, when we realized this was happening with women and men who have sex with women only, we needed to rethink how we were working to reach that population. So this table shows you some characteristics of syphilis in King County in the recent past, May 2021 through April 2023. And I think the key points to pick out are that looking at characteristics among women and men who have sex with women only, there is a higher proportion than among MSM of homelessness or unstable housing, injection drug use, methamphetamine use in particular, and transactional sex, exchanging for money or drugs. And that is really specific characteristics of a population that we needed to design ways to reach and that our clinical services often aren't reaching. So that was part of how the idea came about. Our DIS in investigating these cases noted that very often people had a history of jail incarceration or even multiple in and out experiences in the jail. One of the jails in King County is the South Correctional Entity, or SCORE jail. So you'll hear us refer to that as SCORE. The map on the right shows you central Seattle, that little rectangle above, and then you can see how much larger King County is geographically than Seattle. And this conglomeration of cities in South King County together own the SCORE jail. This jail houses people pre-trial, like all jails. Make a quick distinguishing fact that I think most of you know, but prison is post-trial and is usually long-term incarceration. Jail is pre-trial and is typically quite short. This particular jail actually only books people with misdemeanors. So that means people have a very short length of stay and are often in and out. It also means the population has a very high prevalence of injection drug use, homelessness, the other characteristics.
Do you know anything about someone coming to install nameplates and things?
Could everyone please just double check their mute? Thank you. All right, so we implemented syphilis testing again. That's much of what was driving it. We also did HIV testing and Hep C testing. And our rationale for this is those three really are syndemic. They're all also available. There are point of care tests available for all of them. So one really important point thinking about syphilis, we're using a point of care test that is a treponemal specific antibody. That's the kind that stays positive for life once someone has had syphilis. And so when that's positive, you don't know with that test alone whether that reflects a past infection that was treated or a new infection, or less likely a false positive. But we made the decision and we have gone forward with treating that presumptively as a syphilis infection and trying to deliver treatment empirically while awaiting confirmatory testing. Happy to talk more about that in the discussion. Great, so now I'll turn it over to Luis Enrique and just let me know when you need me to move the slides forward.
Perfect, thank you, Julie. Good afternoon, everyone. In the next few slides, I will be reviewing our testing workflow and our follow-up for reactive results. The diagram above will kind of represent that workflow. We started testing at SCORE in November 2021, and over the last year and a half, our processes and procedures have evolved. So what I'm going to be going over today is what our current processes are. Funding for testing at SCORE jail activities is 1 FTE, and this is split among 2 DIS. So 0.5 DIS are sharing these responsibilities. So we conduct testing 4 days a week for about 3 hours. Each DIS works about 2 shifts. We worked with correction officers to identify the best times to test, and currently that has resulted in testing in between lunch and in between dinner times, which is around 1 p.m. to 4 p.m. Our partnership with the SCORE jail consisted of a long-term security clearance. And we do renew that annually. And this has allowed us to move relatively freely throughout the jail as needed and going to areas where we have business. And that usually is entering the facility and navigating between the medical clinic and the social services area where testing is conducted. And each testing visit can go anywhere from 10 to 20 minutes, just depending on someone's, the testing that someone agreed to doing that day and the results. Correction officers are offering testing to all incarcerated persons by a general announcement, and in some cases do take special requests from folks to be tested for HIV, syphilis, and Hep C. Each day we check in with the correction officer who is on duty, and we do set up in a private space and what is usually used for other interviews and other social services that are offered as part of this program. So this social services, like I mentioned earlier, is designated and houses a variety of different programs from housing access with different community organizations. It also is a space where mental health visits are conducted. So this is a space that does house a lot of social services that are offered or are accessed by incarcerated persons. Next slide, Julie. Thank you. This next slide kind of goes more in depth into the day-to-day implementation of our testing. And if folks do have questions, we can discuss in more detail during the discussing portion. So first, we welcome and gather a verbal consent, just an acknowledgement of why they are here today, right? So we do ask, are you interested in HIV, syphilis, and Hep C testing? Then that is followed with just collecting our documentation signatures for consent to do the testing and acknowledgement of our privacy practices. Second, we begin with intake and registration by either creating a chart in our medical records, or if we do find an existing chart, like Julie mentioned earlier, a lot of folks have been in and out of jails, so a likelihood that we have a pre-existing chart is pretty high. Being able to use our EMR in the SCORE jail did require us to do a couple, take an additional couple steps by setting up two-factor authentication, which required a key fob that lets us access our medical records remotely. Third step, we begin specimen collection. During this time, we review each tests, how they work, and talk about what a negative result, positive result can look like. This way, folks kind of know what's going on at all times. And after specimen collection is complete, we return to completing some of our intake information and our sexual health and risk evaluations. While these tests are processing, we provide information and education. Our specific point of care tests, for example, HIV takes about 60 seconds for results. Syphilis test takes about 10 minutes, and our Hep C rapid testing takes about 20 minutes. As you can see in the visual above, a lot of the evaluation portion happens throughout the visit as a strategy for us to kind of build rapport, answer questions. It's kind of embedded in our conversations. We do later on have a space both in our medical records log and a separate data set that we do document the responses to some of our sexual health and risk factors that we go over with patients. Lastly, we review results with folks. So negative results, we relate to patient, we record in patient's charts and in our end of day reporting, which I'll go into in more depth in a moment. Positive results. So after reviewing results, answering any initial questions, for syphilis specifically, our DIS and myself conduct a partner services interview and refer folks to SCORE for treatment and or confirmatory testing. Usually this happens the following day, but can take a little bit longer. So with positive syphilis testing, again, treatment is usually done at SCORE for the duration that individuals are at SCORE. HIV testing, for positive results, treatment and confirmatory testing can be done or initiated while at SCORE. And usually we have a couple of DIS who work HIV specifically that they take on those cases at that point. For the Hep C positive tests has been one of the challenges to get folks into follow-up, but our protocol currently is to review local programs that exist, maybe somewhere that's close to where a patient may have access to. So refer to local programs, offer follow-up with our specific public health Hep C program. Can you go back? Julie. Okay. When patients complete testing, as just something fun, we do offer a treat or a candy for folks. Note that when correction officers are recruiting folks, that's not what we lead with. Usually when the first person has returned back to their holding cell and they do have this treat, that kind of in itself incentivizes other people to want to test with us. At the end of day report, we send all the individuals who tested, both negative and positives, to the medical team at SCORE, and they schedule each patient for follow-up the following day. Again, may not happen right the following day. In the next few slides, I'll go over in a little bit more or in some detail what our follow-up for positive results and in particular with syphilis kind of looks like. So we, as part of our end of day report, when someone does test positive, we start with sending a couple reminders, both for ourselves using our own Outlook calendars, and we also work with SCORE Gel to kind of set an alert in a patient's profile that kindly requests that they let either myself or the individual who tested the person about what the progress looks like for patient's release. Something that we've learned is that individuals' release date isn't set in stone. So this usually means that there are other jurisdictions that have additional charges, that sort of thing that may keep folks in a little bit longer or get transferred over to a different jurisdiction. We continue to, so we initially set some reminders to help us keep on top of folks, and along with some regular checking in, monitoring of treatment, either while at SCORE or once someone has been released. So if someone completes treatment at SCORE or they complete treatment once they're released, usually that's our win. We at that point, for those individuals, we continue with supporting with partner notification and then partner treatment and testing. If someone starts treatment at SCORE, we just continue to monitor till their treatment is completed at SCORE. If someone is set to be released prior to completing treatment, we will follow up and complete a treatment plan. This can happen at the time we're seeing individuals, especially one of the questions we do ask is, do you know when your release date is? So if we have that information beforehand, and I would say it's true for most cases, that we create a treatment plan with that individual. And in the next slide, I'm going to just go over that a little bit more. Oh, sorry, that slide. Thank you, Julie. So for treatment plan, this usually consists of identifying a provider that the patient feels comfortable going to, or something that's accessible. If not, we have various clinics in South King County, and our clinic, which is located in central downtown Seattle area. So we just identify a place that someone feels comfortable going and have a plan for that. So we know where to follow up, either with the facility or the patient, to see if they were successful at getting to that point. We do offer a couple of support, either with supporting ourselves transportation, or arranging some transportation using our county vehicles. In some cases, bus tickets, taxi, or a ride share option. We do work in collaboration with SCORE because they do have a set of funds that actually they're using to get people ride share to different appointments. So that's a little bit about like kind of what the treatment plan consists of. And if someone decides to come to our clinic in central Seattle, we do offer incentives and such as gift cards. And for wrapping up this slide with partner services, again, during interviews, after we identify a potential new case of syphilis, we do conduct our DRIS partner services interview, identify any partners, reach out to those partners, and support with offer testing and treatment. Next slide. So in the next few slides, I'm just going to go over some key points and some results that have come about with our testing at SCORE. This first slide kind of just goes over the amount of visits that we essentially had at SCORE. So this is beginning November 2021 up to current date, May 2023. We had about 1,425 visits. Keep in mind, these are visits, not necessarily individual. So one person could, over the last year and a half, had multiple visits. Next slide. Thank you, Julie. This next slide, key point here is women were more likely to test positive. So this graph here just shows testing by gender. So men on the left, women on the right, and women were more likely to test positive. Thank you. Okay. This next slide kind of breaks that down. So this is reactive tests only, breaks that down by race. Key point here are people who test positive are disproportionately Black, Indigenous, people of color compared to white, non-Hispanic populations. Next slide, thank you. Here, this next slide compares syphilis reactive by gender, by patient's gender and gender of sex partners, compared to the overall population of of people with syphilis in King County, those diagnosed at SCORE were more likely to be women and cisgender men who have sex with women. And this next slide. Okay. This next slide represents new cases. So there were about 67 positive tests from our intervention. And here about 67% or about 45 of these reactive syphilis health check tests were true new cases. And here in the figure, 22 either had a prior history or a different factor that made them not a case. Next slide. Thank you. This next slide goes over treatment. So of the 45 new cases that were identified through our testing, about 55% of new cases were untreated or did not complete treatment. And not complete treatment refers to folks who initiated either through 1 dose, 2 doses of penicillin, or were prescribed doxy, but were released prior to completing, and through our follow-up, weren't able to successfully get them finish treatment. Next slide. Okay. So I am extremely proud of the work that we have done at SCORE, and I think this next graph kind of has a salute to that. So there were about 58 cases that came out of the SCORE facility, and with the way our reporting works and the way we use our surveillance program, any of our tests that we did ourselves at SCORE are categorized under a SCORE as the facility. So SCORE Gel, so this is the SCORE medical team that already exists there, had about 13 new cases during the same period of time, November 2021 to May 2023. And this represents that the work that we have done. So 76% of new cases found through our DRIS intervention testing at SCORE. The next slide. So this next slide goes over number of syphilis cases diagnosed at SCORE among King County residents. So you'll see that on the left, that number is a little bit smaller, 31, right? But that refers to folks who had a address in King County. So this is not including the other set of individuals who were tested by us, tested positive for a new infection, but reported an address outside of King County. And SCORE GIS consisted of about 3% of new cases identified among King County residents. Thank you. And the next 2 slides are just going to briefly summarize just some information around Hep C and HIV. The percent of men and women testing positive for Hep C was about 12% for both groups. Okay. And for HIV, we did identify 3 new cases of HIV through this work, and this resembles what we are seeing generally with other interventions throughout the county. So it reflects very similar data that we're seeing at the SCORE. Perfect. Lessons learned. Okay. So a couple of the best practices, I think, and I'm not sure how true this is in other jurisdictions, but it was critical that we had this partnership with the social services department at SCORE, because it was an easy way to have support through correction officers, because us as DIS aren't just walking around polling people. So it took a lot of coordination and support from this existing program that adding HIV testing, STI testing to like social work, support and resources. It was crucial for our success, and building really strong relationships with correction officers. I think that has been crucial. A lot of us are on first name basis with folks, and again, they support us with recruiting folks. So that has been really critical. Some of the lessons learned. Remote access to Epic was one of the best changes I think that we made, because this not only saved time outside of SCORE in charting and duplicating work. It did require us to be able to provide a little bit more support in the sense of providing the key fobs to be able to access our EMR electronically, because cell phones aren't allowed further than booking. So we had to come up with a better strategy to be more efficient with our time. And part of that was implementing an electronic medical records at testing. We also learned that working with the corrections officers to strategize around the best time to test, I think, is one of the biggest things that that changed from when we initiated this work. When we first initiated this work, we were there about 8 hours, so that was 9 to about 4-ish. So we were there for a long period of time, and through observations, I noticed that we weren't seeing very many people in the morning hours, because a lot of the capacity for the officers were used among some of the other resources and some of the other program support resources that were happening. So what we did is we narrowed that down to about 3 hours. And what that resulted in is not a huge change in how many people we saw. So when SCORE had a dedicated period of time that they can essentially dedicate to us in recruiting folks for testing, we did not see a change in how many people we saw for the most part. And the number of reactives that we were seeing per month stayed the same, if not increased. So we were just more strategic about when and how we were utilizing some of our time and efforts to make this as efficient as possible. And I'll turn it over to Julie for the next couple points.
Thank you very much, Luis, Enrique. And I know we need to finish up, so I do want to just briefly say that we are working, our biggest challenge, without a doubt, is getting people appropriate treatment. And we are working to build a stronger relationship with the medical team and come up with some new approaches to ensuring that that happens. So in summary and conclusion, our testing at SCORE has been effective at identifying new syphilis cases, particularly in key populations. The relationships with the programs department and correctional officers are really key, and we need to work on treatment completion. So thank you so much.
Thank you both so much for taking the time and effort to just share all that information with us. Thank you so much. So we have we have still until 4:15 Eastern, so we still have time. We have looks like about 20 questions in our chat for you both. So Leo and Aaron Fratto are going to support in facilitating that discussion.
Thank you so much, Sonia, and thank you so much, Luis, Enrique, and Julie. Aaron and I are going to do our best to get through these questions for you, and if not, then we will be happy to share those. But the first question is around lab-based testing. Why would lab-based testing not be successful? I ask because the HCV screening send out is quite a bit cheaper for us than the HCV POC or quit.
Yeah, that's a great question. It's really just the time involved. So the process of sending it out and getting results back is too long in most jail settings to get the results to people and get treatment while they're there.
Another question following up on that, is there a blood draw set up for confirmatory testing, or do you refer directly to treatment?
We do try to do both together. So as Luis Enrique described, people with positive tests, that report goes to the medical team. And the idea is for the medical team to both treat them and draw confirmatory blood tests at that time.
Do you use opt-in, opt-out, mandatory testing? What is your refusal rate?
So definitely
Yeah.
opt-in optional. Luis Enrique, what would you say is the refusal rate?
I mean, I would say essentially it's zero because it becomes really clear for folks when they're being recruited, whether they want to do it. And again, I take and my coworkers take an extra step and just, this is why you're here. Is this still something that you want to do? We haven't had anyone really that I can recall that halfway through testing was like, actually, I don't want to do any of this and refuse. So usually folks are there because they either want the candy from their cellmates or they're generally seeking STI HIV services.
And Luis Enrique, this might be kind of a follow-up to that, but a participant pointed out that consent is very different on the inside. How do you provide that consenting process? How is that conducted? Who has access to the test result? And what about partner notification?
Yeah, so let me break that down a little bit, right? We do initiate with just a verbal consent, just letting folks at the beginning know, hey, this is going to be a process where we're testing for these infections. This is what it requires, right? A blood sample, so a puncture in someone's finger for some blood. So to begin with, we kind of just give folks an idea of like what they're potentially agreeing to. Along with documentation, we have our intake and registration process requires us to have documented signatures for consent to bill and test, but there isn't any billing going on, along with some of acknowledgement of our privacy practices that involve folks' HIPAA rights. Again, only times that we will share information is going to be with our partnership with the medical team when someone does need treatment.
Thank you, Luis Enrique. The next question is the EMR in the jail medical, is the EMR the jail medical provider's EMR or a public health's EMR?
It is public health's EMR.
And going along with the EMR question, does the jail also get the result in the jail's EMR so the jail facility clinical team has access to view it and follow up, kind of the sharing of that information in EMR systems?
So when the follow-up is done with the blood draw, that is all actually done by the SCORE medical staff. So it's run through their processes. For example, they use LabCorp. So they get those results resulted to them. But in Washington State, any positive results for syphilis, a subset of that sample is forwarded on to our state public health lab, and essentially the lab is run again. So sometimes we have two titers, that's its own issue. So usually, because of the reporting requirements in Washington State, we eventually get the results for any testing done at SCORE. They come through our surveillance workflow. But part of getting results and identifying whether it's a new case or not can happen immediately with just myself or my coworkers calling into SCORE and making sure that testing happened and treatment was at least initiated. But again, that information will pop up again in our surveillance for Washington State.
Awesome. So the next couple of questions is around facility staffing. So This question is, are SCORE employees King County employees, or is the medical team an independent contractor?
Yeah, so that's a really good question. So SCORE Jail, so South Correctional Entity, is not a county owned, like we mentioned at the beginning. So they are it's a conglomerate of cities that own this jail. So it's not our electronic medical records, it's not our King County staff. So it is a third party company that does facilitate all their medical services.
A staffing question. Are there staff alongside the program staff, like the correctional facility staff? What does that look like, the tag team?
Yeah, so all the program staff located at the social services area are correction officers. So there technically isn't individuals who aren't correction officers kind of managing the social services area. So it's usually one correction officer, maybe two on during busier times, that are facilitating bringing in folks from their holding cells to receive a variety of services, including HIV STI testing. So about one or two correction officers supporting that work specifically. And Lieutenant Gepner, who oversees the entire program, also a correction officer.
Awesome. And then I think that this may have been discussed earlier, but if you could just kind of reiterate, do you have DIS embedded in the jail?
No, not in SCORE jail. That has been this partnership where we send out, right now we have two DIS splitting a lot of these responsibilities. So we have our own county DIS going into SCORE jail to do this testing. And similarly, in our county-owned jails or county-run jails, we as well don't have DIS embedded in those facilities yet. Something that is in the works with our county facilities.
Switching gears back to services, can you tell us what percentage of people booked into SCOREs end up getting tested?
Yeah, that's a really good question. So at any point in time, population in SCORE is about 400. And we see about anywhere from 60 to potentially 100 people per month. So it's a really small number of folks that we have capacity to see compared to what the entire population of SCORE jail is. But just as a reference point, I don't have, I can't give really a percentage, but roughly there are about 400 individuals housed at any point in time. And daily we can see about anywhere from 6 to 8, maybe 10 if everyone's just doing an HIV test. But usually that's what our capacity has been set. Keeping in mind that this includes not necessarily an added barrier or challenge, but folks are polled. So correction officers have to walk over to where folks are being housed and are brought to us. So sometimes that takes a moment of time.
Awesome. And are you only testing upon intake, or can folks opt for testing after intake?
Yeah, so all of our testing is post-intake. Like we mentioned earlier, there's usually a general announcement done once folks are already through the intake process. So all of the testing happens once someone's, for us anyway, happens after someone has completed intake. Not sure if folks are routinely screened by the medical staff upon upon intake, and Julie's nodding no. Probably not. Yeah. So all of that happens post intake.
And just another question along the lines of testing and treatment. Can you talk some more about folks who did not receive treatment or did not complete treatment? Was it only because they were released, or were there other factors involved? Do you know anything about treatment outcomes for folks who were released prior to completing treatment? And then can you also just kind of talk about the process if someone moves to a different jail in a different county?
Yeah, these are all great questions. So the reasons that people don't complete treatment, I would say there are three key factors. So yes, there's the key one that they are released beforehand. The second one, which is related, is this issue of 3 weeks of treatment being needed for syphilis of unknown duration. And honestly, I think a lot of those are probably early cases, and we've been rethinking our approach to that. But it's very hard to get a full 3 weeks of treatment while someone is in jail. And despite all our efforts to get that treated after release, we essentially don't effectively connect with people after release. And the third one is trickier, which is that there are some providers who I think aren't fully on board with the empiric treatment option and would prefer to wait for confirmatory tests. But of course, then what happens is by the time the confirmatory tests come back, the person's gone. So we've tried to have some ongoing conversations about that, but that is part of when we say a better relationship with the medical team, that's really what we're talking about trying to make happen. Luis Enrique, do you want to comment on that at all?
Completely agree. That's one of the key factors, I think. I have personally, as someone who's facing and on the front line working with the medical staff, is right, kill them with kindness. That way we can get to some agreed upon or get on the same page with empiric treatment.
Thanks so much. And Julie or Luis Enrique, can you just speak to if the person moves to a different jail or a different county, is there any contact or coordination with that county or jail for treatment or partner services interviews?
I think that depends would be my answer. So there's no one system that all the jails share that would contain information like this person has syphilis and needs treatment. If they end up there are some jails that communicate and some that don't. So what I would say is that's spotty and we don't have a system to coordinate across jails.
And something that I'll just add to that, usually in some cases, once someone is not released but transferred out of SCORE jail, sometimes we know where they're going. And if it is a county operated jail, that's I would say quite much easier for us to coordinate with their medical staff because they're county employees. We can send messages internally. Coordination is easier when we know they're being released or transferred to a King County jail. But we do attempt to identify who, if they were transferred to a different jail, where in the state. Usually that may not be very successful, but I would say it's coordinating with the county run jails does make it a little bit more successful.
And I will just hop on here. This is Erin Fraudo with NCSD. Our next workshop is actually going to really focus on the cost of treatment, ways to save money, ways to get medical services on board. There's some pretty big implications here with public health partnerships. So we will dive into that next workshop session. So make sure you show up and we'll talk about money, 340B, treatment access, leverage, all sorts of things.
Thanks so much, Erin, for that plug.
Yep, I was just going to throw it back to you for another question.
Sure thing, I have plenty. Can you provide more details about the 55% of new cases untreated? Is untreated at SCORE or among all cases? What are the challenges to follow up with treatment plans for new cases released before finishing treatment at SCORE. And I think this is kind of similar to the previous question.
Yeah, like I mentioned, the graph that we illustrated before around the 55%, that is current information that we have for folks post-release. I would say one of the biggest barriers is the majority of the folks who do test positive are unstably housed, and in a lot of cases, having that contact information is not always available. I think one of the strategies that we do use is when someone doesn't have a form of contact or a residence, right? We try to build a plan with them that can support us not being able to like immediately talk to someone. And in some cases, that is, what is a place that you usually hang out? And if we stop by any given day of the week, chances that we could connect with you would be high. Again, the incomplete treatment stemming from folks being released prior to completing treatment. And there were a couple of instances of just folks refusing to get treated under the untreated category. But for the most part, that refers to folks who were released prior to confirmatory testing and treatment.
Let's bring in some urine samples and swabs with this question. Does the jail test for chlamydia and gonorrhea in addition to the blood drawn rapid tests for syphilis, HIV, and Hep C?
No, we don't do swabs. We've just done the blood tests, and that was a decision about priorities and feasibility. So I am an STI person. I appreciate that question, and it wasn't worth the extra lift to get swabs.
So much along those lines around testing and treatment. Who provides medical care in the jail? Is it a public or private entity?
It is a private entity that contracts with the jail and several other jails to provide health care.
And I'm guessing since there's no urine collection happening, we have a question about pregnancy testing. Does the program offer any sort of pregnancy testing?
That would be done with the medical assessment. Once, if it's a pregnancy capable person who has a positive rapid and they're being evaluated by the medical person, that should be done then. Yes, important question. So not the DIS doing that, but that is the point at which the medical provider is doing that.
Great. So switching gears just for a second, jumping back to just thinking about the process that you all went through to develop your partnership. Can you talk more about how you got the buy-in to do this work? Was there pushback at all about this adding to the workload of the jail medical staff? And if so, how did you work through that?
Yeah, so Lieutenant Gepner, who Luis Enrique mentioned earlier, was an established partner of ours. And when I say ours, I mean the HIV, STI, hepatitis C program at Public Health. And part of that had developed out of giving them rapid HIV tests. They were interested in having rapid HIV tests. We supplied them for them. I do think an important thing to say, he's a pretty special person and he wanted to make things work in the jail. And so it was, I think a lot of the success of this program is the fact that we were already having ongoing conversations with him about public health. And that once we posed this question of could we come into the jail and do this, once he was on board, he's essentially the decision maker that makes everything happen. So like so many things, a lot of these things do depend on individual people. And I suspect you'll be talking a lot in this collaborative about how to develop those relationships.
Do you have any more questions on that theme, Leo? I'm going to switch gears, take us in a different direction.
Actually, I do have one more question in that category. Are there any additional requirements for collecting testing treatment data on patients in a jail setting IRB review?
Yeah, this is not research. So the IRB has oversight over research. And if we were doing research, absolutely, there would be a much higher threshold for people in jail and for reviewing this. Since this is not research and this is a public health program, no. Luis Enrique, let me know if I'm missing something, but we're essentially collecting the same data we do when we test people or do partner services in our sexual health clinic. Less information, actually, not more.
Correct.
So I should have used outreach testing rather than our sexual health clinic as the example.
Yeah.
Thank you so much. Erin, I'll turn it over to you to switch gears.
Great. Lots of correctional facilities are very hesitant to allow any sort of testing because of the liability of treatment and the cost. Did that come up in your conversation, or is that something that you've navigated? And do you have any clear protocols about treatment?
Yeah, that is a great question. And this is one where I think the three infections are really different. So for HIV and for hepatitis C, we as the health department are essentially saying, it's the same thing we did with emergency rooms, right? To me, this is a great analogy. We are essentially saying we will take on the responsibility of coordinating and getting people into care. So when someone is diagnosed with HIV, we public health know we do everything we can to get that person linked to care. Ideally, we would do that with hepatitis C. The truth is those efforts have not yet been very successful and I think need more resources. So really where this comes up is syphilis, which needs to be treated in the jail and isn't something we can sort of take over as a county. And we have had a lot of issues around 340B and bicillin. I'd be happy to join your cost conversation if you want. I think going into that in detail is a bit beyond the scope of what I can answer right now. But actually, I'm sorry, Leo, I do just want to emphasize with emergency rooms, it was the same thing, right? We don't want to test for HIV because then we need to follow up and are we liable? And so we really had the discussions to say we, the health department and our partner services program are taking on that responsibility. And I think that is a big part of getting buy-in from the organizations.
Great. Leo, did you have any other questions? I have one about PrEP being discussed upon release. If you don't have any other.
No, Erin, I have no other questions in the Q&A as of now.
Perfect. We are the best Vanna Whites. Okay, is PrEP discussed for post-release?
Yeah, so PrEP is discussed as part of our sexual health risk evaluations. So we have conversations with individuals at time of either a positive result, in particular with syphilis and HIV, but which was there were less infections. We have a conversation really with this population that hasn't resulted of like, oh, I want to start PrEP. Can you help me start PrEP once I'm released? And initiating PrEP at jail, I think the infrastructure really isn't there to so I mean I think it can be, and I think it could be part of our workflow and our lift to get folks the necessary coverage to start PrEP even at jail. I think is feasible, but I guess I'm referring more to like the demand that those conversations result in with this particular population hasn't been something that folks have wanted to pursue. We do offer education. We do offer information about what PrEP is and how it could benefit individuals who are testing positive for syphilis. Yes, I think folks want more clarity on that. I can.
Thank you so much again, Julie and Luis Enrique. We really, really appreciate you just taking the time to be so thorough in your questions. Erin, are we pausing on the questions? I know that there were a couple that we may not have answered or asked. Erin is going to take the lead on those questions in our next workshop. Again, that's going to be implementation. So a couple of items. we're looking forward to developing a service delivery toolkit at the end of our webinar series. So aiming to have that available in July once the series finishes. The second part of our series will focus on the logistics of service delivery. And I can give it to Erin for a moment if she wants to kind of plug in a little bit more content there. That's going to take place Wednesday, 6/14 at 3 p.m. Eastern. And there is the QR code. Hopefully this QR code works. I didn't test it myself, but that's the QR code for the link to register. And you can also find the link to register. It will be up later this afternoon, hopefully on our event page for the workshop. Erin, do you want to add anything on part 2 before I add to part 3?
Yeah, no, just a quick soundbite. We'll be talking about 340B. There were several questions in the chat about 340B. We'll be talking about the public health partnership and providing 340B eligibility. We'll also be talking about bicillin delivery and how DIS can support treatment. But again, we'll also be talking about how to strongly encourage a correctional facility to provide that treatment themselves. Join us.
Thank you so much, Erin. And then part 3 will take place on the 28th, again at 3 p.m. And we're going to aim to share that registration link next week. And that's going to focus on assessing impact and ways that we can sustain testing within incarceration facilities. And thank you again, everyone, for joining us. If you have questions, feel free to reach out to myself. I realized I didn't introduce myself at the beginning. My name is Sonia Khan. If you don't already know my name or face, the Senior Manager of Disease Intervention and DIS here at NCSD. Please feel free to reach out to me if anything comes up last minute. And if you also have questions for our presenters, I can also add their contact information. Or can we actually, no, hold on. Can you both add your contact information back into the chat? That way we don't have to go back a million slides. And thank you again to Julie and Luis Enrique for your time and commitment to expanding testing services and the efforts that your program is providing. Thank you so much.